Good evening, sir.
Good evening.
Good evening,
Should I?
aspirants. Today's class is on maternal medicine, MRCP Part 1. It will be taken by Dr. Susovan Mitra. He is MBBS Calcutta MD, MRCP UK, DIP EP, RCGP UK, MEM SEMI, Fellowship in Critical Care Medicine, MGR University. He is a member of Royal College of Physicians, London, Chairman, Indian Society of Critical Care Medicine, Chennai, and is a member of American College of Physicians. And he's a Chief Critical Care Physician, Jerry Care Hospital, Chennai. So, sir, I hand over the class to you. You can begin the class.
Oh, thank you, Mitra, for such a wonderful introductions. Okay,
Thank you, sir.
I think yeah, I will like to start now the class. Before I start, a few things. Like the maternal medicine is a little bit basically predominantly the topic of part one. There are some questions can come in part two, but it's a predominantly topic on part one. Now, the maternal medicine questions, if you go through your popular question banks, like I would always recommend for past medicine or the past test, whatever it is, or on examinations, you will not have separate session for maternal medicine. Like each session, you will have like few the cardiology or dermatology or endocrine, they will have the maternal medicine questions, one or two questions separately. So the maternal medicine topic, which is predominantly there in the Kalra book, which is the exclusively for the part one. And the Kalra, they will have the topics each one, they have categorized it. So you will get the question 2 to 3 questions in the real exams. And for that, or you have to know this thing very categorically. This is the normal, different from the normal patients, how you are reading with that. So I have tried to jot down all the changes which is happening during the pregnancy and what all the diseases can come in pregnancy and how do you do that, including dermatology and all. Those who are listening from the subcontinental and the Indian scenario, they will find out little difficult or different, rather, I will say, in the scenarios and the values. Please don't correlate with your current practice because this is predominantly for the Royal College to practice in UK. Keep this in background. We will start the session. Now, why the pregnancy is most important? If you see this picture, it will make you more clarified that the pregnancy where you are dealing with the mother and the baby. And there are a lot of changes. The person who is pregnant, she will go through it from all the systems, from the brain, from the respiratory, cardiovascular, renal, thyroid, GI, hematological, hormones, everywhere you can see. If this picture is very clear on your screen, you can see all the systems where separately will have different impact. Always, if you see a pregnant lady, if you do a blood gas, you will find out she is having the respiratory alkalosis because she is blowing out the PCO2. You always find out that the patient having some symptoms of cardiovascular disease, like patient will having tachypnea, they will have high heart rate, and they will have increased cardiac output. So all the systems will have differently. It impacted the pregnancy, and these are equally important because all these systems are maybe become very physiological, or the exaggerated effect of physiological will have some pathological impact on the body. This keep it in background. Let's start. We'll see that how we are going to deal with that. Give me a moment. I hope it is very clear. If somebody just tell me.
Yes, sir.
Okay. So I'm sure it is visible. Okay. So as I was telling that the physiology of pregnancy has impact all the systems and body, and each of the systems adapt according to their capability to adapt the normal demand of basically the fetus. So the fetus, more specifically the feto-placental unit. And normally the pregnancy complications can arise because of the exacerbated physiological adaptations if it is not occurred. So we'll see by one system. Let's start with the cardiovascular system. Now, usually, what is happening in pregnancy that you will have increased the plasma volume from 2006 to 2.6 liter to 3.8 liter mostly. Basically, it will reach in the plateau by the 32 weeks, 32 40 weeks of gestations. So, and the cardiac output will increase by the 40%. That, as I mentioned it here. Now, why the cardiac output is increased? Basically, because of cardiac output is nothing but the heart rate and the stroke volume. In pregnancy, the heart rate will increase and stroke volume is also increased. So subsequently, the cardiac output is also in increase, and it will always go up to 4.5 liter to 6 liter per minute. This will go in the plateau by the 24 to 30 weeks, and the cardiac output mostly increase more in the second stage of labor. Please important that the questions multiple times in ask in part 1 that the which stage the cardiac output is more. It's in the labor, it is the second stage of labor, and it will go the plateau up to the 30 weeks of gestations. And there is an increase in the heart rate and increase in stroke volume, which I always mentioned it like that. This is important when you are reading like this. There is also a physiological left ventricular hypertrophy, and the dilatation with the left ventricular is always happen due to increase in the cardiac output. But the contractility remains same. The structural things is reversible, and it will go back to in reversible postpartum state by the 6 weeks. Equally important. Let's keep this one. Question has been asked this also multiple times on that which is age, it is go back like that. Now, because of this points, that is important things. If you are dealing with that, there is increase. There is a increase in the vasodilation. Peripheral vasodilation will be increased, but there is no increase of pulmonary PVR, pulmonary vascular resistance, or SVR, systemic vascular resistance. The capillary wedge pressure remains same. And when this kind of capillary wedge pressure remains same but stroke volume increase, they are prone to develop pulmonary edema. That's why it is very common that the pulmonary edema is more common, or peripartum cardiomyopathy is more common in second stage of labor up to the 15 days of postpartum. This is important piece of information. Kindly imprint this in your brain, that the postpartum or peripartum cardiomyopathy is very common in second stage of labor up to the 15 days of postpartum. And this is because of you have an increased stroke volume, which will go by up to the 6 weeks. But in the second stage of labor, it won't go to peak. And because of capillary wedge pressure is not increasing, because there is decreases SVR and PVR, they are prone to develop peripartum cardiomyopathy. I'm not going to detail each one things that how cardiomyocytes happening in pregnancy. I will deal with only the exam related questions and all that. Now, next, because of upward displacement of the diaphragm, the heart of the apex is moved little less towards the left. And that is why you will see some ST changes, the ST depression changes, and T wave inversion in the lead 3. And also there will be the left axis deviation. A very important point, please note it down. These are the common physiological finding in ECG in pregnancy. So if you are getting this kind of pregnancy in the real clinical scenario also, this is not pathological. You have to correlate clinically at that point of time. And this questions has been always asked that the ECG changes regarding that. Is there it is important or not? Please note it down in there. If you do the echo, you will find out little bit of pericardial effusion and the MR, regurgitation, mostly mitral regurgitations and all, valvular regurgitation, which is because of the dilatations. This is also is the physiological. This can become pathological based on your previous heart vascular resistance or diastolic dysfunction. We are not going to detail in this part, but I just wanted to let you know. Yes, correct. Stress cardiomyopathy. It can happen like that way. I'm not coming in detail that it can produce Takasubus cardiomyopathy also. if you keep think. This is the reason for it, as I told you. But Takawasu's cardiomyopathy usually questions never ask, but in different way. Those who are practice in critical care, we deal with this left and right is post pregnancy. This is what it's happened like that way.
Excuse me, sir.
Now, yes, yes,
You
yes.
told this there is a mix of pulmonary edema during the second part of the postpartum pregnancy. So can you tell again this mechanism of this pulmonary edema?
Sorry, come it again.
Can you explain
I
again
didn't
the
understand.
mechanism of that findings of pulmonary edema in the second part of this delivery?
So that the second stage of labor up to 14 weeks of the postpartum, yeah, they are prone for develop pulmonary edema. Because of these patients, cardiac output has been increased. Cardiac output has been increased because of this is okay. I'm not going deep. Please remember, this is basically class of this is a very valid question what you ask, but this need to have more detail about the postpartum and peripartum cardiomyopathy. That itself is a 1 hour topic. I will just give you few things, points that you have to read around. I'll tell you why. The patient's cardiac output is increased because of heart rate and stroke volume is increased. Patient is also having the vasodilatation because of the endothelial factor, nitrous oxide synthetase. That is why the patient was vasodilated and patient's cardiac output is increased. But patient's capillary wedge pressure will be not increased because of the SVR and PVR, pulmonary vascular resistance, and stroke systemic vascular resistance will be decreased. Because of this mismatch, they are prone to develop the pulmonary edema, peripartum or postpartum cardiomyopathy. Now, this has to be very much, there are a lot of physiological changes happen, including the cardiomyocytes and the chemical changes in the level of peripheral vascular as well as in the level of the pulmonary capillary wedge pressure level. Because of this mismatch, they are prone to develop peripartum cardiomyopathy. That's why we always keep in back of your mind when I'm that this stage, we have to be very careful about the volume restriction. If you give the volume in this rate, they are prone to develop volume restriction. Though they will appear to you clinically at bedside, they will be volume depleted. So the dictum is very clear. You should not overhydrate them in this scenario. Post-pregnancy, like we try to give you a lot of IV fluids. This is actually a decremental that can go. That is why I specifically put that point. It's very important for us in knowing that. The second stage of labor, patient's cardiac output, there's also a pain factor because of the level of pains, and that's why a lot of bradykinins will secrete, and that's why the level of cardiac output go its peak in the labor. That's why I mentioned that way. So that's the basic gist of pulmonary edema, why develop. Now, this is the just only thing. There are a lot of mechanism chemically, how nitrous oxide synthetase is happening, how prostaglandin is happening. That's a separate way. If I explain, then today I'll finish it up with that only. So that's the reason. If we are doing one class separately, I'll take for that, the particularly peripartum cardiomyopathy. Is that okay? Yeah. So move it to that, keep it in back of your mind. No problem. You're welcome. That keep it in mind that there will be decrease in total peripheral resistance, and that will increase the further cardiac output. So that because of that, there will be decrease in the blood pressure. Now, this is important. That's why I was mentioning that you will feel like because there is a decrease in total peripheral resistance, there will be increased cardiac output, and then you will see little decline in the blood pressure up to 36 weeks. And this is that increase the vasodilator. This generally accommodate lot of blood flow to the uterus and the other organs. And this is why you will appear that they will appear like a little bit of vasodilated or little bit of volume depleted. Keep it in back of your mind. Now that this is where you have the changes in, basically these changes happen in cardiology.